chief of the endocrinology section at University of Louisville Hospital. She has been very active in the clinical field, developing new and improved programs both at the university and at the VA. She has been a very active clinical investigator. She's on the board of the VA Clinical Research Foundation and has been over the last 10 years participated and been an investigator in most of the pivotal studies in diabetes and obesity. She is well known for her passion for education. All our fellows, residents, and medical students can attest to that. And one of the things that she has done is develop clinical programs for pump clinics and fine needle aspiration for thyroid, bariatric follow-up clinics, and a long-standing clinical program that she has been involved with in collaboration with the Cystic Fibrosis program, which is run by the pulmonary division, is the Cystic Fibrosis Diabetes Clinic. So today she'll be talking to us about this topic of cystic fibrosis-related endocrinopathies, which is a growing field. So, Dr. Krishnasamy.
Thank you, Dr. Mukshiganam. Thank you, Dr. Mukshiganam, for the very nice introduction. Sorry for the few minutes of technical delay. I'll try to catch up as we are on air. So the reason I chose this topic is multiple reasons. One is it is a great model of what you call as interdisciplinary care of a patient. Number two is it is an amazing journey of what we call as precision of personalized medicine in the field of pulmonary and genetics and related fields. And also a year or two ago, when I was doing the mix-up questions with the residents, we noted that there were one or two questions based on CF-related diabetes. So I felt like I'll accomplish all that in this. We were supposed to have an earlier looping video with music from Australian singer, which was because I was dedicating this talk to our former coordinator, program coordinator and nurse. Many of you all know her, Kay Burris. She passed away in 2019 while she was, I think, the day after she finished her work here and went home. So, she was very dedicated and very, close to my heart. And we all have a wonderful team here. Many of them are here today also from the CF clinic in the 4th floor of the hospital-based clinic. So I'll get started here. And these are my disclosures, nothing relevant to my talk. And also, these are the objectives. You've already seen them in the email that Jason sent to us. And mostly, we are going to talk about 3 different areas. And given the time constraints, I may have to adjust a few things. But mostly, we are looking at the CFTR gene, the protein, which is very fascinating for different reasons. And second, we are going to look at complications. This is an uncommon disease, as you all know, but it has common complications. And that's where me and my division and my team comes in. And also the fascinating advances we've had in the world of diabetes, including the technology. If I can incorporate everything that I'm passionate about in the next 40 minutes, that'll be great. So in the 1800s, going back a little bit, in the 1800s, CF was called a salty kiss. And this is in German, so I'll use the English version of here. Woe is the child kissed on the forehead who tastes salty, for it's cursed and soon must die. Fast forward 100 years, it's a female physician, Dorothy Anderson, who defined cystic fibrosis, first of the pancreas, the cystic fibrosis of the pancreas, and also started using pancreatic enzyme replacement to treat these patients. And she also speculated it is a recessive disease, which she rightly so did, and also connected that it could be related to the lung and the intestine. And since then, fast forward, we have come this far. And it is a monogenic disease. It affects just over 100,000 people worldwide, perhaps a lot more, but we do not probably get to see the full spectrum of it because of some issues we have in other countries other than North America and Europe. So it is 35,000 Americans live with CF, about 1 in 20 to 25 of European ancestry or carriers. And it is a monogenic disease, like I mentioned earlier. And the mutated gene is for the chloride ion channel. And it was, in the next slide, I'll talk about the discovery of the gene, which really fast forwarded all the advances we have now. And it's while the most common gene mutation is the delta F508, which is about 2/3 of the patients in the United States. However, there are other more frequent mutations, more so almost the less 1/3 of other mutations are also present. So this was in 1989 that we had this major breakthrough. You may recognize the scientist here. It's the former head of NIH, Dr. Collins and colleagues. And he discovered the mutation. And there's a history to the mutation CF gene. It goes all the way back to the Stone Ages, 50,000-year-old gene. And it's been said that it was first introduced in Europe in the Basques of Spain about 50,000 years ago, and again reintroduced 10,000 years ago when farming and agriculture started. And it's 3 base pairs of the nucleotides coding in, this is on chromosome 7, and missing position 508 phenylalanine causes deletion of phenylalanine causes the mutation and the disease. And like I said, there are other mutations also, but we are most common is this, and this is the one where we have the small molecule modulators, which is a major breakthrough again within the last 10 to 15 years. So much of what we know with CF has been over the last 20, 30 years with animal models. More so recently, we are looking at tissue cultures. But the animal models, similarity is more homogeneity with humans, with pigs and ferrets. However, there are some studies using mice and rats. While the lung homogeneity is there in the knockout, interestingly, the pancreas similarities are more so with the mammalian models, the ferret and the pigs. And much of the studies were done at the University of Iowa, the Fraternal Order of Eagles Diabetes Center, and also by the pulmonary division there, Dr. Stolz and Dr. Engelhardt. So what are the structural airway abnormalities? This one is a rat with CF, a newborn rat. And as you can see, this is the normal, the wild type and the knockout, absent cartilages and tracheal stenosis. Well, the next one is actually newborn pig, which also shows similar changes with major damage to the cartilages and stenosis. And this is sinuses. The red is the ethmoid and the green is the maxillary wild type. And this is the knockout. And these are 3D images of, I think, 3D tomographies. And as you can see, the ethmoid sinus is almost missing in this pig. And this is the CT of the lungs of a newborn pig showing mucus plugging already. And the humans show the similar sort of arrangements where you could see air trapping and mucus plugging. And so how do we make this diagnosis? Number one, suspicion. And number two is evidence of CFTR dysfunction. And I hope my animation works. I borrowed some slides from Dr. Ramirez and CF Foundation, but we'll look at it first. So suspicion, siblings with CF, positive newborn screen, which is a major breakthrough that happened in early millennium. And also clinical symptoms consisting with CF, 1 or more organ systems, chronic sign of pulmonary disease, gastrointestinal nutritional abnormalities, salt loss syndromes, obstructive azoospermia. In fact, interestingly, one of my patients, who also was a healthcare provider, wasn't diagnosed until he was in his 30s and I think early 40s, where he suffered from multiple sinus infection all his life, multiple pneumonias, and finally, an astute pulmonologist put it together. And when he came to see me for the diabetes part, he said, Dr. Krish, nobody ever could tell me why I couldn't have children. So it was quite sad what happened, and hopefully that will not happen. And this is an infant undergoing a sweat chloride test, which is something we screen. So evidence of CFTR mutation is elevated sweat chloride, and this is how it's done. And also two disease-causing. You need two copies of disease-causing CFTR mutations and an abnormal nasal potential difference. And we don't make a diagnosis of full-blown CF based on just that. We certainly have a few patients who have the positive criteria but do not fit the clinical criteria. So we call those patients screen positive inconclusive CF SPID or CFRM, which is cystic fibrosis related metabolic syndrome. Because when they are 100% fully functional, healthy individuals, and as the mutation function drops to 0%, that's when you get the full spectrum of the disease. So what is the global genetic epidemiology? Well, the incidence is about 1 in 3,500 to 5,000 live births. It's in North America, Australia, and in Northern Europe. But there's substantial regional variation. As you can see, parts of Europe where there's 95% detection rate, we in Canada and United States, Australia do quite well, but there are parts of other countries where they have higher priorities, such as communicable diseases and other catastrophes, and they're not able to provide the funding. So it is felt that there's a lot of missing, there's a lot of heterogeneity, and there's missing patients, especially in Africa. And I deleted the slide because of time constraints, but showed that they have the capacity, but they don't have the money available to diagnose these patients. So the mortality many times is much higher. So in United States, we have this wonderful tool called the Cystic Fibrosis Registry. And those in the audience who were researchers, educators, house staff, this is a great registry for data mining. And if you have a very good idea and apply for funding or apply for data, they are able to get you the data if there's enough scientific merit to the information that you're looking at. So the CF patients, about 32, 35, like I mentioned earlier, the mean age has advanced. It used to be 18 years in 2007, and now it's 24. And adults over 18 years, the percent is 60%. And the mixed racial spread is 90% European ancestry, 4 to 5% African-American, and the other races are about 5%. And that's sort of reflected in our CF clinic here also, about 100 patients that we have, 105, and we have about 10 to 12 African-American patients. So the advances in CF over time, 1930s when Anderson first sort of described the disease, and then the salt in the sweat, and then the sweat chloride was developed, and then the CF protein in the 80s. 90s, the gene is identified, and 2007, newborn screen becomes universal in North America. And further on, fast forward 2007 to 2022, we are looking at small molecule immune modulators and anti-inflammatory antimicrobials for resistant bugs such as Pseudomonas and Staphylococcus, and also gene therapies such as CRISPR. So we have come this far. And one of the reasons we in the adult CF clinic, which many of the team members are here, are very involved is, look at these numbers in the 90s. The percent of adults was 32%. And 30 years later, 2022, adult surviving adults is about 60%, and it is still growing. So we are now doing what we enjoy doing, which is take care of these patients as they age, as they start families, and look into problems such as of aging and cardiovascular disease, so obesity and diabetes and bone health and everything. So as I mentioned earlier, it's a multi-system disease. Upper, lower airways, intestines, pancreas, biliary tree, cervix, cervical mucus is involved, vas deferens, and sweat glands, and a few other areas. So the clinical manifestations related to pancreas sufficiency and insufficiency, which even can include urinary stones because of malabsorption, hypochloremic metabolic alkalosis and dehydration, meconium ileus, which many times is present at birth, and CFTR mutation-related disorders, such as primary sclerosing cholangitis, cervical mucus abnormalities causing not infertility, we call it subfertility, and recurrent pancreatitis, and CBAVD, which is congenital bilateral absence of the vas deferens. And the complications, which I was mentioning earlier, such as GI complications. We do have Dr. Rosso now with us, part of the team who addresses the GI issues, and bone health and anxiety and depression. Mental health is a big issue. These patients who are on multiple medications have been sick since childhood and have a lot to deal with, but many of them do very well with intervention. Oh, the animation works. Thank you, Dr. Ramirez. So this is your CF chloride channel. As you can see, this could have been your rhinosinuses, or it could be your lung. So the CF chloride channel with the ions, the chloride ions. So when everything works well and the mucocilia keep moving, all is good. When the protein is mutated, then becomes a problem because there's mucus plugging and mucus accumulation, which I'll show in a second. And this is your normal mucosa or cilia. And when there's a CFTR defect and there's dysfunction, either there's not enough production or it is produced, but it's not processed very well. And there's misfolding and other problems. So there's a class 1 is not enough production or synthesis defect. Class 2 is processing defect. And it's unable to pull itself all the way up to the gating here to the channels, where it has to work with the airway surface liquid layer called ASL to prevent mucus formation. So when there's the CFTR dysfunction, we see this mucus plugging that you see here. And this is the chloride channel gating, and normal function. There are several channels here, and all is good. It's working fine, and the chloride ions are released. Well, there's a folding or trafficking defect, which is where it's not being pulled up to the surface. So there's a problem there. And again, gating defect where there's enough channels there, but they don't gate and conduct and open. So those are the common mutations, although there are total about 6 to 7 mutations, but 2 and 3 are the most common, and 2 is where we associate with Delta 508. Well, the small molecule modulators, immune modulators that were developed early millennium and fast forward 2019, we have at least the most important and the most powerful one, Trikafta, which is 3-in-1 immune modulator. When the patient is treated with these, they go in and they fix the problem. This is the Golgi apparatus here. And it starts improving the synthesis and also starts taking the channels up there. The channels open and they start gating. And as you can see, the open channels here, and all works well. So Trikafta has really, which is the most recent immune modulator developed in 2019, has changed the landscape of how we treat these patients and how much in terms of longevity, improved pulmonary function, nutrition, etc. So FDA approved, like I mentioned, right before pandemic. So many of our patients went on this triple therapy combination. They're called highly effective modulator therapy. And the treatment is approved for more than 90% of the patients because most of them have delta 508. Initially was approved in over 12 years and in adults, and later on it was approved if they were over age 6. And this is the data between 2015 to 2022, the number of patients on immune modulators. And as you can see here in 22, almost 80%, at least in our center, we have, I think, almost close to 90% on immune modulator. And how has that changed the aspects of the disease? Well, it has helped the bronchitis, bronchiectasis, the sinusitis, and the metabolic aspects, which is weight gain, improved BMI, improved FEV1. However, the pancreas, especially the endocrine pancreas, we're not sure, has not helped the liver as much. So there's some fatty liver disease, portal hypertension, cirrhosis, and does not help the fertility aspects, but it does help the women with the cervical mucus abnormality. So that's a very important aspect of what I do at the CF clinic. So, and watch here with the transplants, patients receiving transplants, and from 2019 on to 2022, the rates of transplant dropped, and that's when the triple modulator was introduced, and that has increased, although that is the same time that pandemic started. So one would not be sure which caused it, but the survival advantage is there between 90s and now to 22, in 5-year intervals. And there's amazing, and right now the survival advantage is up to median predicted survival is 56 years from being 10 years early 19th century to 20s in the 1980s. So what are the complications, and what is the most common complication? Well, you can see here, this is a 6-year-old, 6 to 10 years old, and all the way up to 40s. The red broken lines is diabetes. The purple lines are bone disease. And then the green lines are depression, which is mental health, and the joint problems. So this is from 2012. The CF diabetes still in adults, almost 30 to 50%. In our center, it's about 30%. Depending on the centers, the prevalence in the adults is 30 to 50%, which is pretty much almost many of the adults as they get older. This animation is not working, but that's okay, this is the CF bone disease. It's a couple of mention about a couple of words about this. So this is animal model, wild type, and it's a CFTR knockout. And this has animation where it shows the porosity. Interestingly, CFTR mutation is present at birth in the bones, and there's increased porosity, more so in the cortical bone than the trabecular bone for many reasons. And these patients have developed bone disease early on, and there are screening guidelines, and there are multiple factors for developing low bone density. Most importantly is pancreas nutritional issues, growing up, a low BMI over time, which is associated with low bone mass, and also height velocity is decreased because of sort of a disconnect between growth hormone and IGF-1. There's decreased physical activity because most of them are on treatments and able to move a whole lot. There's inflammation, there's insulin deficiency, impaired glucose metabolism, and also a direct effect of the CFTR and steroids and immobilization and hypogonadism in some of the male CF patients. And all those together impact the bone health. And the prevalence as of now in 2022 in the CF bone disease is higher as they age, as you can see here. And what are the interventions? First is screening for these patients, and the CF has foundation has very good guidelines for screening, and adequate calcium intake. And as you all know, fat-soluble vitamins in patients with exocrine pancreatitis is a big issue. So they're all on DECA vitamins. It's vitamin D, K, and rest. And our center nutritionist, pharmacists, clinical pharmacists, they all do a great job of keeping up with their supplies and doing a great job with education. So the next area is diabetes. As I talked about, the diabetes in CF is a little bit different from the usual diabetes that you're all familiar with. We have type 2 diabetes, which is the most prevalent. There's type 1, which is immune diabetes. And but this diabetes is called diabetes of the exocrine pancreatic diseases. It's called type 3C, or pancreatogenic diabetes. So these patients have chronic, this is not just CF, it's also seen in several other disease conditions, hemochromatosis, fibrocalculus, pancreatopathy, rare genetic disorders, there's idiopathic forms, and also with pancreatic cancer and post-recurrent and acute and chronic pancreatitis. I don't know how well the slide shows, but any exocrine pancreas disease can impact the endocrine beta cell and cause diabetes of the pancreas. And these patients, there is anomalies in the islet cell, and there's an intrinsic defect in the beta cells and the alpha cells. Also, they have insulin resistance, especially when they're sick and when they're on steroids, and there's infection, and there's islet amyloid. As we can see here, this is a pancreatic duct of a pig, which shows mucus plugging of the ductules, and that causes compromise of the beta cells. They become more dedifferentiated over time, and due to impaired vasculature. And also there's incretins are impaired also in a complex sort of connection, and the vasculature is compromised. So a lot of things happen in these pancreases. And as I mentioned earlier, most of what we know about the CF pancreas comes from the ferret pancreas. And you can see it here. The inflammation is present in the newborn CF patient, the ferret. And this is a non-CF wild type and CF newborn, and advanced to 32. By 9th day, the inflammation markers are quite high in these pancreases. So just a couple of, just to mention about the different cells of the islets, and what happens when they're lost, because that's what happens here in type 3C diabetes. The alpha cell, which makes glucagon, when the alpha cell is lost, severe hypoglycemia happens, and there's a lower response to high blood sugars, and also there's a development of diabetes, that's the 3C, but there's a reduced risk of DKA as opposed to type 1 diabetes, where you have loss of beta cells, but alpha cells are there, there's glucagon, so they do develop DKA. So that's one of the differences. Although they look alike, they're both lean, they both have low BMI, but the immune or the autoimmune type 1 is different from the 3C diabetes. The beta cells, we won't go into too much detail, but definitely lack of that causes increased hepatic gluconeogenesis. And also the delta and the pancreatic polypeptide cells are also lost. And here again, there's hepatic insulin resistance when the polypeptide is lost, and there's hypoglycemia. So this is the beta cell, and as you can see here, there's the CFTR channel that sort of works along with the potassium channels for release of insulin when glucose is taken up by the GLUT2 through the GLUT2 channels. There's release of insulin, and when there is abnormality of the CFTR, the mutation happens, and the beta cells are affected. So, we already talked about how there's insulin insufficiency because the beta cell is dedifferentiated, but there's also loss of beta cells, and there's insulin resistance when they're sick. So this is a very interesting disease where you have both sensitivity issues and resistance issues. And so screening for this condition has to be started very young, almost when the child is 10 years old. In the pediatric CF clinic, And the screening is with oral glucose tolerance test, and that is quite a bit of a challenge because it's a 2-hour test. It's drinking the orange drink, 75 grams, and checking blood sugars every hour. And we have tried over the last several years and to sort of come up with newer guidelines with new technology, which is continuous glucose monitors, which many of you all in the audience is familiar with, to see if that can replace the glucose tolerance test. The reason we use glucose tolerance test, which we moved away from OGTT in type 2 diabetes, because we start using A1C. Well, in cystic fibrosis, A1C is not very helpful. You could have a normal A1C and still have the diabetes. And that's why A1C is not used for diagnosis. The gold standard is oral glucose tolerance test. However, if the A1C is high, when they come for the annual evaluation, then you could call them diabetes. But if A1C is normal, it doesn't rule out. So they all undergo annual evaluation, or they should, but it is sometimes very difficult to get that done. And there are caveats to those patients who are on tube feeds, which we have a few patients, especially children on nocturnal tube feeds or daytime tube feeds for low BMI. And those patients, we have different criteria. And those who are in the hospital also, we use different criteria to diagnose diabetes. And there's a very interesting entity called reactive hypoglycemia, which can happen up to 30% of the time when patients have undergo the OGTT. And that is something we see with the delayed release of the first phase insulin and a poorly timed second phase, which comes in and causes hypoglycemia with diminished glucagon response. And some of our patients see us just for that and not for diabetes. When looking at the data of reactive hypoglycemia and longitudinally, if they are at higher risk for CFRD, we have seen that that doesn't correlate that well. So this is a part which most of us are familiar with, the numbers for glucose tolerance test for diagnosis, normal glucose, impaired fasting glucose, impaired glucose tolerance. So 126, so millimoles and milligrams. There's one entity in CF which is not seen, which we don't talk about in other diabetes, and that's called INDET, which is indeterminate glycemia. We have seen that the 1-hour blood glucose, when it goes up to 200, even at 2 hours when it drops back to normal, these patients are much higher risk of developing diabetes within the next 5 years. And so we do concentrate on these patients with INDET. And what are the determinants of CF-related diabetes, or what are the risk factors? Women, advanced age, lower FEV1, liver dysfunction, and exocrine pancreatitis, steroids, and certain mutations. Like I said, 2 is one of the most severe mutations. Those are risks for that. And why is diabetes so important in these patients? Well, diabetics, there's a higher risk of mortality, at least until recently, with the advent of the immune modulators, that has changed a little, but early millennium, several studies showed that risk of dying was 6 times higher mortality with diabetes. And also there was a very good correlation between lower FEV1 and having CF-related diabetes. Now, one would want to know in the CF patients, what are the complications of having diabetes? Well, they do develop retinopathy sometimes. So any microvascular disease we do see. We at least have a few patients with microalbuminuria, so we do concentrate on them. CKD, dialysis rarely, but many of them do. We at least have one patient who had needed kidney transplant, but that's because he had lung transplant first and developed over time with the drugs, the immunosuppression drugs. So neuropathy and hypoglycemia unawareness is a problem with these patients. Nutrition, I know Dr. Williams is very interested in knowing if we have data on vegan and vegetarian in CF patients. And I did look for it. I found some blogs, but not much data on vegan. But certainly when talking to our dietitian, Laila Healy, who's here in the audience, she said that some patients have been interested to becoming vegan. In fact, one patient who just moved from New York. And also many of them, the recommendation is Mediterranean diet with more vegetables. And but traditionally for CF, the way we recommend was different, mainly because the BMI was low. So you tell them eat all you can, and we'll adjust insulin to make up for that. Well, that's not true anymore because the BMI has changed with the immune modulators. So in type 2, we use caloric restriction. In type 1, we use adjusting based on the growth, weight maintenance, or weight loss. Whereas in CF traditionally, and those guidelines are slowly changing now in the last few years, traditionally we used to say 120 to 150% of RDA, and fat was 40% and 10 to 20% of protein. And we said generously sodium, but that is changing a little bit now in the adults. And exercise, very important. And going to the treatment aspect of it, now is also a year or two ago is when the insulin centenary was celebrated. And these are our the Nobel Prize winners in 1923, actually. They were awarded the Nobel Prize. So last year was the centenary. And it's a major breakthrough in the history of medicine. And the reason I bring that up is because most of our patients who are on treatment, 70% of them are on insulin. Why insulin? Well, traditionally, the patients had lower BMI. They needed to gain weight. And they went on steroids many times. They were hospitalized. So there were wide fluctuations in sugar. So it was easier to titrate insulin. And well, there is a small percent of them on oral agents, but there are issues with in terms of tolerating oral agents, the traditional oral agents such as metformin, when you have exocrine pancreatitis, bloating and diarrhea, different issues. And other agents such as the glinides, sulfonylureas, again, the concern is modulating the treatment based on the blood sugars. And the insulins, and this is a study me and Dr. Abel, we looked at, or a review article we did for gastroparesis a few years ago. And at that time, these were the insulins available. I'm talking about 2018. Since then, we've had more insulins in the landscape. And one of the very fascinating newer insulin is the fast, rapid acting, ultra rapid acting. So many patients do forget sometimes to bolus insulin before the meal. So these patients, many times, this with the ultra rapid acting, they can eat and still take the insulin, and they'll still perhaps have normal postprandial blood sugars with that. So, and these are some of the newer insulins that have come into the market. And of course, we have the concentrated insulins, which are also available if needed. So diabetes technology is the next area. I was looking at, most of us here know at least one person, one of the celebrities in this slide, Nick Jonas, who many may not know. He's a type 1 diabetic. And this is the continuous glucose monitor. He has, I think he has a Tandem or Omnipod, I'm not sure. And this is Quincy the koala from the San Diego Zoo. This is from a few years ago. Quincy had type 1 diabetes, and a generous donor gave a Dexcom, and they were able to monitor Quincy's blood sugar and adjust the insulin. Lila Moss is Kate Moss's daughter. This is the New York fashion walk that she walked in, and that is the first time automated insulin delivery was available, which was wireless, had been just introduced that year, and she's proudly wearing it, as you can see here. That is the insulin pod of Omnipod, and then she has probably got her Dexcom somewhere on her arm. So the technology for continuous glucose monitoring is there's this, it's worn on your skin with this very tiny sensor right here. The understanding is that when you do finger stick blood sugars, you get only certain points in the day, and it is painful, especially in our young adults and children. Whereas when you wear it continuously and monitor it, you see the trends, there's feedback, and more importantly, if they're on insulin, we can avoid and prevent hypoglycemia. There's millions of studies that have proven improvement of hypoglycemia and improvement of A1C using these monitors. There's at least 3 or 4 of them available in the market now, and most of them are pretty close in terms of blood glucose, which is the capillary blood here, and the interstitial blood matching. So this is the sensor here, and glucose molecules in the interstitium. It uses a certain calculation and displays. And before we needed to have a receiver and carry it around. Well, now you can put it on your phone and you can share it with 10 other people, like including your baseball coach for children, if they're going hypo, the nurse, the parents, the aunt, whoever wants to know that. And we couldn't have done what we did for our pregnant patients, CF or otherwise, in early pandemic without technology, because we did do a lot of pregnancies early pandemic, and I have our great diabetes education team from 310 also here, Keisha, and our dietitian Beth. So who without their help we couldn't have done much of what we did. This is your Dexcom, and this is a pregnant patient, 92% in range, which is a dream. And as you can see, the range we used for this patient to be 92% in range was 60 to 130. During pregnancy, we need very tight control. And then she had a receiver. She has her phone. It's on her phone. You could even get it on your Apple Watch, and that's her sensor. And the outcome was a beautiful baby. So what is the other aspects of diabetes technology? In pens or smart pens by itself, it's a talk, so I won't go too much into it, but the hybrid closed loop pumps have made a major breakthrough in this area. We have at least 3 available in the market and 4th being launched very soon. And you see the kid here wearing the wireless, and this one is Medtronic, who are the pioneers in this area of closed loop insulin, where it delivers insulin automatically based on the sensor, and all the patient has to do is put in carbohydrates and do the corrections. Based on algorithm, and every one of them have different algorithm. And ADA, American Diabetes Association, recommendation is that these patients get provided education, and you look at the skill sets of the patient and the family, and also do ongoing evaluation, and also third-party payer commitment to paying for these technology. And we couldn't do it without the diabetes education team. The details of the AID I'm going to skip at this point, but certainly, as you can see here, this is the automated insulin pump. This is a patient's sort of 24 hours of blood glucose variation here, and automated the insulin pump. The patient themselves provide the carbohydrate-based insulin bolus, but the rest of the time, the pump comes in and automatically provides extra insulin to keep the blood sugars more steady. So it has made a big difference in keeping our patients in range. As you can see here, 70% in range, which this patient had a lot of problems in the past, and from 43%, they came all the way to 73%. And some would want to know about SGLT2 and GLP-1. I have one slide on that if we have the time. But cystic fibrosis lung transplantation is an area also that endocrine is involved, because post-transplant with steroids and the calcineurin inhibitors, which can cause post-transplant diabetes. And these patients also develop bone disease. So it's important that we are involved from early on. And I just wanted to give a shout out to everybody in my team at the clinic and at 310 who helps us keep our patients healthy with educating them for the diabetes, for nutrition, pregnancy, and everything. And move on to reproduction. I don't have a timer here. So, so the men with CF have the condition is called with functionality based on the CFTR mutation. 97% have absent vas and atrophic seminal vesicles, causing infertility. And some of them can also develop hypogonadism due to other reasons, and obstructive azoospermia. The picture I showed you earlier is ICSI, which is early on, there is some possibility of extracting sperm and helping with infertility. The women, on the other hand, have a different challenge. It's called subfertility, and that's related to the cervical mucus. The cervical mucus is thick, so it is hard to, ovulation is also very, not very regular. And the trikafta, which is the three drugs together combined in one, that has made a big difference in terms of the fertility. The cervical mucus is more amenable to impregnation, and there's more pregnancies now than we used to before 2019. So, but CFRD, which is cystic fibrosis-related diabetes, is a risk for pregnancy, also for C-sections, for congenital abnormalities, and also for other issues such as during pregnancy with other complications. So it's very important to address the CF-related diabetes in our young women who are planning families, which many of them are, as they're living longer and the BMI is better and they feel better. So we do what we do with the safety checklist, so that nothing like what happened in the Boeing last week happens. So we go through them with the medications, make sure they start their prenatal vitamins, contraception if they're not ready, make sure the A1C is good, they get their eye exams regularly, their PFTs, and also counseling if needed for the partner, because remember, there's 2 copies that you have to have the child. And this is one very successful pregnancy that we had, healthy baby delivered at 38 weeks pregnancy, and that's always a favorable outcome. I will skip this part of an interesting story and move on to obesity, which is the last area. Certainly, as you can see, between 95 and 2020, obesity did go up, or BMIs did go up. This is overweight and obese youth with CF. And part of the reason is the small molecule immune modulators. And in our own center in the 2012, as opposed to now at 2022, BMI has moved up. So has the FEV1, which is a big marker. So then we would ask, well, what about the game-changing GLP-1s, would they make a big difference in this group? We do not have a lot of data on GLP-1, but we are hoping and looking into more studies. This was a case report presented at the recent North American CF conference that showed just 5 months follow-up of using a GLP-1, Wegovy or semaglutide for weight loss where the patient tolerated it well. However, the concerns is that these patients have pancreatitis, excess weight loss, constipation, bowel obstruction. So that is always a concern. So what is the future? Personalized therapies, non-insulin deliveries, and most importantly, curing CF. I hope in the given time, was able to go over all the topics that we had hoped to cover. In this area, this is older picture. I think Jason helped me get this picture about 4 or 5 years ago. The pediatric CF center, walking the bridge that connects the pediatric to the adult. The hospital, 4th floor of the HCOC is where our clinic is, right next to the high-risk MFM with Eddie Miller, and also with the clinical trials unit. We are well situated there. We have a great team, and you need a mask to enter the place. So that's very important. And it's one of my favorite phrases from by Ratan Tata, who's a visionary from India. If you want to walk fast, walk alone. If you want to walk far, walk together. And I think that's relevant to this area. And I wanted to thank everybody who's here and everybody who's virtually here. And this is the team. This is a recent picture. Also wanted to thank my division, our fellows, faculty and everyone in 10. Thank you all. Sorry, not too many minutes left.
Thank you. That was a wonderful looking at the entire scope of what it is that we're facing. And I'm glad you mentioned the nutrition part, because it was something that always was interesting to me, that you have books, anecdotes, a lot of the CFF Foundation pushing plant-based diet, but nobody's talking about mechanisms. Nobody's doing a clinical trial that I can see. But the anecdotes are thick. I mean, I came off the transplant list for my lungs, and
Yes.
writing books on it to tell you how to do it, but not telling you why, is just not satisfying for those in nutrition medicine. So I'm wondering what are the possibilities that we can get something started here and look at some real mechanisms. The two obvious ones are the dramatic reduction in inflammation when you stop eating animal products.
Yes.
And the other one is infection. That is, there are no infections that aren't improved in terms of the severity, including COVID, by doing a plant-based diet. But are those two mechanisms enough? And maybe it's the pancreatic inflammation you're talking about that decreases the severity of diabetes, for example. I can imagine a bunch of stuff, but it needs to be studied.
Yes, yes. We don't have evidence, and believe me, I looked and looked because I knew the question would come up, and I even talked to Laila and said, "Are we doing?" And that's when we talked about, discussed about this spectrum of patients, and then. One of the things I also see is the finances of patients and where they come from, how much their access is. We have some patients who live in trailers and all they can afford is fast food. And to try and get them to go into this, it is a lot of effort, but I think more and more patients are buying into it. The first is to get the parents or the caregivers and involved, and then the patient. The whole family has to change, not just the patient.
Right.
And many of this starts in utero, not just as adult. So, and because this starts in utero. So very interestingly, one thing I wanted to mention was the immune modulator Trikafta. There was a patient who both the dad and the mom were carriers, but didn't have the disease. But when they did the ultrasound of the pregnant mom, they found the fetus had the meconium ileus. And they did give the mom the Trikafta, and the meconium ileus improved in the fetus. And when fetus was born and they did a newborn screen, the CFTR mutation was not there. So we have come a long way. Yes, that was a case report. So we've really made a vast difference. And I think the nutrition aspect is very important as they're all getting older. I have at least one patient on statin. One patient has a family history of heart disease, and many of our lung transplant patients do develop, cardiovascular disease. So it is very important, that area. So thank you. Any other questions? I know it's past close to 9. Oh, okay.
Dr. May wants to know, do you recommend physical exercise for patients with CF?
So exercise in CF, and again, our respiratory therapist is not here, but pulmonary rehab and respiratory therapy is a very important component of CF patients right from childhood. In fact, large sections at the National North American CF conferences are dedicated to PT, physical therapists, and rehab specialists. The picture I showed you, and I went through it a little fast because of time, but the patient is wearing a Hillrom vest, a Monarch vest it's called, that helps them to do airway clearance. So starting from that all the way to any activity, based on the child's FEV1 and based on others, and perhaps the team, rest of them can give more information on that. But physical activity is definitely does improve their PFTs and everything if they're able to. So.
That's all from the chat.
Oh, okay, thank you very much. Oh. So higher mortality costs, yes. So CF diabetes decreases FEV1, higher infection rates. And also, I think apart from just beyond all that, there's also certain specific infections that are slightly higher. The Borrelia cepacia, Buckdorfia cepacia, and that seemed to be higher in patients with CF diabetes. So there are multiple reasons.
And what about cardiovascular?
So interestingly, now that I think the oldest patient we have is what, in their 70s now?
Okay.
Yeah, so interestingly, as they are getting to that, we are beginning to see, the other aspects of this. And of course, post-lung transplant and then pulmonary hypertension and right heart hypertrophy, those kind of things are also there. So yeah, so all specialties are involved in these patients, yeah.
Well,
Thank you very much.